Thank you, everyone. Thank you for the kind invitation. It's my pleasure to be here in this beautiful location. Thank you, Raymond, and thank you, Dr. Fraser, for the kind words. It's indeed our privilege to be here, and I'm going to get things started discussing CLL basics. So those are my disclosures. And I always like to start with the statistics. So in 2024, there are expected of close to 25,000 new cases of CLL. And as we know, having CLL means that you're going to live a very long time. So the prevalence of CLL is very high. It's over 215,000 people living with CLL in the United States. It's a disease that tends to occur later in life, with 2/3 of the patient being age 65 or older. It's also a disease that has a prevalence for the male gender and for white race. Those are the characteristics. So how do we diagnose CLL? The criteria for the diagnosis have been revised during the years. The last edition is from 2018. And what you need to do, you need to see in your peripheral blood work. You need to have more than 5,000 lymphocytes. This should be sustained for at least 3 months. Those lymphocytes are unique. They have some expression of certain antigen that is really a hallmark of the disease, in particular the presence of the expression on the CLLs, on the same cells of a T-cell antigen that is CD5 and a B-cell antigen that is CD19 that is normally not found anywhere in the body but for a very tiny amount of lymphocytes in the tonsils. So whenever you see this population in the growing in your blood, then the diagnosis of CLL can be reached. This is how the peripheral blood smear when you take the cells and you put them on a glass slide. Those cells undergo a mechanical trauma, and this is why we have this typical appearance with what is called smudge cells. And when we look at them at a higher power view, we see that those are really fragment, broken cells. And according to where you are in the world, they will have different names. In the US and probably in Canada, they are more commonly called smudge or basket cells. In Europe, where I come from, we use the German word of Gumprecht shadows. And I thought that was a nice little fact. This is how the cells look. They are small, they have a very large nucleus compared to the cytoplasm, and they are really unique in their morphology. When we do bone marrows at MD Anderson, we tend to be traditional. We come from Texas, conservative, not all of us. So we tend to do bone marrow at diagnosis, and you can see that the bone marrow is replaced by this population of really unique cells, that they give this appearance of really replacing a large proportion of the bone marrow, and they can have a pattern that can be either diffuse or interstitial, and this is a higher magnification of a bone marrow. As I said before, you need to identify these unique cells with a CD19, CD5 co-expression, and also they're going to have only one of the 2 options that we have for immunoglobulin surface immunoglobulin. They're going to be either kappa or lambda. Sometimes there is a little bit of a difficulties because we do have what we call the gray zone, where the characteristic of the cells are not quite typical of CLL. In that case, you need to expand your panel, you need to add some more antigen, and when you look at the gray zone, a particular importance is to make sure that there is a difference between the diagnosis of CLL and the one of mantle cell lymphoma. And to rule out mantle cell lymphoma, we often conduct a test for cyclin D1, that is a typical test for mantle cell lymphoma and allows to exclude that the condition you have in front of you is mantle cell lymphoma. This is how those gray zone lymphoproliferative disorders belong to. They belong to the group of the CD19 positive lymphoproliferative disorder. And as we see, CLL is characterized by being CD5 positive with the CD23 and surface immunoglobulin co-expression. When I meet with the patients in my clinic for the first time, we usually have a discussion about the diagnosis, because when you look at the pathology report, you're going to have CLL/SLL. So the usual question I get is, do I have leukemia or do I have lymphoma? So my way to explain is that those are really two sides of the same coin. The disease is the same, the cell of origin is the same, but there is a presentation that is different. With CLL, the disease is more in the blood and in the bone marrow. It can also be in the lymph nodes, of course, but the main presentation is the one of an elevated lymphocyte count of more than 5,000. In small lymphocytic lymphoma, instead, we don't have this, but we do have evidence of enlarged lymphadenopathies. There is also a condition called monoclonal B lymphocytosis that is a precursor of CLL. And in this condition, you can identify the typical cell for CLL, but there is no presence of an elevated lymphocyte count, and there is not the presence of enlarged lymphadenopathies. So again, the presentation of CLL can be mostly with an elevation in the white count. Nowadays, this is often done for a routine blood count, often maybe just your yearly routine visit with your PCP, or even for insurance reason or any other test. But additional presentation can be with enlarged lymphadenopathies. Most of the times, those lymphadenopathies that are recognized are often in the neck, because either your family will notice it or you will notice the presence of those enlarged lymphadenopathies. Liver or spleen can be enlarged, and they can give some symptoms, or at times what is noted is frequent infection, weight loss, or occasionally the disease can present with the abrupt onset of anemia or thrombocytopenia. Majority of people with CLL have what we call sporadic CLL. And one question that is very common is why? Why do we have CLL? The answer is we really don't know. There are some conditions that have been identified as an association with CLL. And this is exposure to ionizing radiation, like after the Chernobyl atomic disaster. The Veteran Administration in the US recognizes exposure to Agent Orange as a possible reason for CLL. We know that if you have a rheumatological condition or an autoimmune disease and you have to take immunosuppressive medication, there is an association with CLL. Like every leukemia, there is a positive association with smoking and exposure to chemicals. However, 1 out of 10 patients can have what is called familial CLL. So familial CLL is a real entity. There are families where this is more common. Follows a dominance inheritance pattern. When it's from the paternal side, it tends to be transmitted most commonly to the youngest son. There is no preference when it's on the maternal side. What we see is multiple siblings with CLL, and there is a phenomenon called anticipation, where each generation is diagnosed sooner. Of course, this could be in part because of the knowledge of the presence of the disease in the family, and I always tell my patients with familial CLL that their family member don't need to worry because the chances is still small, but they should request that a blood count is done yearly, and they should tell their primary care physician not to worry only about cholesterol and triglyceride, but that in their family the blood count needs also to be checked. Often in family member you can find a small clone, what we define as the MBL clone, and there is a condition that was reported that is a POT1, that is a familial predisposition syndrome for cancer, where among the unique type of cancer that you see with this condition, there is also an increase of CLL. And this can be identified on genomic testing. We actually do have a leukemia predisposition clinic where we refer patients with CLL for genomic studies. The clinical course of the CLL is often initially asymptomatic, but then there could be an increase in the size of the lymph node, there could be some progressive bone marrow involvement, and also sometimes you can have the consequences of a decreased immunoglobulin level with an increased risk of infections. And then some unique situation like transformation to Richter, that fortunately is very rare, and autoimmune phenomenon. The staging of CLL, I call it the poor people staging, because all you need is a blood count and the person in front of you. In the United States, we follow the RAI staging, but in Europe, and I think in Canada too, no, you follow RAI. In Europe, they follow the Binet stage. They're all very similar, they're all very simple. They're based on the presence of the lymphocytosis, presence of lymph node, and then an impact on anemia, on production of red cells, anemia, and production of platelet thrombocytopenia. What are the indications to start treatment? As we know, we don't start treatment on everyone, but we need to watch for B symptoms, including weight loss. We need to monitor the lymphocyte count and look at the absolute lymphocyte count. We worry when there is a lymphocyte doubling time that is 6 months or less. Of course, once we have fairly elevated blood count, watch for anemia, thrombocytopenia, autoimmune complication. Occasionally, there can be extranodal involvement. Some people may have CLL lesion in the skin or in the GI tract as the most common presentation. So this is another discussion I often have with the people that come to my clinic. Doc, what do you say? I have leukemia, you're going to watch me. Yes, that's how it is. So, and that is because through the years, there has really not been a proof that intervening early is helpful. What I say is I want the disease to declare itself. I want to get to learn what is your pattern. And this was shown in the early years. This is probably one of the oldest slides I ever show. It's from 1998 from Dr. Diguero that showed that early intervention with chlorambucil did not result in a benefit. And moving forward to 2025, a paper freshly published by our colleague and friends in Germany, Dr. Langerbeens, CLL12, showed that again, an early intervention is not beneficial. And in this case, it's an early intervention with a modern targeted agent with ibrutinib. Patients were divided between two groups, patients with low risk according to the German system that is based on LDH, white count, presence of the lesion 17P, lymph nodes. Patients that were in the low group, they were observed. Patients in the intermediate, high, or very high group were divided equally, 1-to-1, between receiving ibrutinib or receiving placebo. Those are the graphs. I don't want anyone to study this graph in details, but the most important information is summarized in the table on the side. It says no difference in survival between patients treated with ibrutinib and placebo. And that is what counts. Survival is the strongest endpoint of ever, because survival means going to, grandchildren first communion, graduations, and being part of the family. Really, the other endpoints are not so important. However, this study did show that, of course, if you start treatment early with ibrutinib, you are going to delay the need for a subsequent treatment, or you're going to delay progression. But there is, nowadays, Based on this study, still not a recommendation to start early treatment. What are the prognostic factors that are associated with a more aggressive disease, a shorter survival? The most important is probably the TP53 mutation by NGS. This was really a scary finding a few years ago. Now treatment has improved so much, as my colleagues will show you later in the morning, that is not as much of a concern, but it still needs to be taken in consideration when treatment is planned. Mutation status of the immunoglobulin heavy chain gene, it really helps us to understand the disease dynamic and the disease kinetic, but is not quite as relevant as before. The cytogenetic abnormality is something that I like to obtain and I still monitor very closely. There were some other factors like ZAP70 and CD38 that they have really lost their importance nowadays. I like these pictures because I like visual images. This is the so-called FISH test. It's a really neat test. What you do, you put a certain color on each piece of the chromosomes, and then you look at the cells that they are not dividing. So it's easy to do because the cells don't need to be dividing. And you look, for example, if you're looking for patient with a deletion 11q, you look for cells that have only one color where the 11q is. That in this case was a green dot just in the middle of the screen. Or if you want to look for trisomy 12, on the bottom right, you will look at cells that have 3 dots that light up on the site of the trisomy 12. Very interesting test. And why this is important? Because starting in now 25 years ago, in 2000, Dr. Doher from the German group showed how this FISH classification is very important for survival. Of course, survival nowadays are very different from what you see on these slides, but we call this hierarchical classification from the worst one to the best one. And they can be found in about 80% of people that have CLL. The most common is also the most favorable is the deletion 13q. And at presentation, the worst one, that is the deletion 17p, is quite rare, between 5 and 10%. The other test is the immunoglobulin heavy chain gene rearrangement. We look at variation from germline. It can be considered almost a test of the maturity of your cells. And so the cells that are mature tend to be mutated, and they have a slower growing and a slower kinetic. So having a mutated immunoglobulin heavy chain gene is a favorable feature associated with more indolent behavior in your disease. And this was shown 26 years ago by Terry Ambling in England, that also showed how patients with mutated immunoglobulin heavy chain gene have a better survival with respect to patients with unmutated immunoglobulin heavy chain gene. Now we talk about TP53. There are different ways to test for this. It's important to use, whenever it's possible, the NGS testing, because the NGS testing is going to be able to detect the larger number of abnormality of TP53. And TP53 is something that should really be tested also at any new therapy. When someone has to go through different therapies, it's good to test for TP53 before starting any line of therapy. At MD Anderson, again, we like information. We use a very large panel. We call it End Lymphoma Panel because we share it with our colleagues in the lymphoma session. And I circle here some that are important information for the patients with CLL. The presence of an ATM, the presence of Notch, the presence of TP53, POT1 that we reviewed before. And then when you go through treatment, this panel is also helpful to identify any possible resistance toward the targeted therapy, the BTK mutation, the PLC gamma 2 mutation, and the BCL2 mutation can be associated with the less likelihood of responding to a certain agent. This is the CLL International Prognostic Index that looks at, again, the same factor, puts them together and compute a risk score. However, I wouldn't spend much time trying to learn these, because what we know is that now with the new targeted therapy, actually the CLL IPI, this International Prognostic Index, doesn't really have an important predictive value. When you look at the two curves and you move to the one to the right, you can see how there is really not a separation of the curves based on CLL IPI with the new targeted therapy. So again, targeted therapy are changing the world of CLL, and a lot of work that was done in the past is not relevant anymore. We need to move to new horizon. So what we do is really working. So I always like to show this because it's by the SIR, that is the organization in the US that reviews the statistical for all the patients with different disease, including cancer, is the Surveillance and End Results Agency. We can see that the 5 years relative survival for anyone with CLL is 88.5%, and if we go back and look at what it was in 1975, it was only 68%. And the estimated survival for 2022 is even higher at 94%. So I think this shows really the great progress that we have in CLL. However, I would like to now focus on another topic, that is the immunodysfunction and the unique complications that people with CLL have. And as Raymond said, sometimes you may need to change your habits or at least adjust. Those are mainly hypogammaglobulinemia, the susceptibility to autoimmune phenomena. Vaccination are important, even if the activity may not be as strong as on a person without CLL. And then cancer screening is really paramount for health. Those is a review of the complications. The most common one are autoimmune cytopenia. You could develop hemolytic anemia, where your hemoglobin, your red count goes down, and there are some other changes, including possibly becoming jaundice and developing some yellowish in the skin. The same thing can happen with the platelets. There can be a sudden decrease in the platelet count. This can happen for no reason, or sometimes can be triggered by an infection or a change in medication. Very rarely there is pure red cell aplasia, where a bone marrow really goes into shutdown, or a decrease in the white count, particularly in the neutrophil. There can be also some very unique complication, for example, the development of a coagulation defect, tendency to bleed, especially at time of surgeries due to acquiring von Willebrand disease, problem with the kidneys related to glomerulonephritis. Those are rare complications, but it's important for the physicians and for the patient to be aware about them. What do we do? In some cases, when there is one of these complications, it's pretty easy. We can just treat with prednisone and the complication goes away. However, in many cases, because the real trigger is the underlying CLL, what we do is start therapy for CLL. And this, with CLL-directed therapy, we often have very good results. And this is a review that we did with one of our fellows. In Texas, there are a lot of mosquitoes. I don't know about Canada, but whenever my patients come to my clinics, they say that they have a terrible time with mosquito bites. And this is real. What happens is that often in CLL, we have what is a hypersensitivity to mosquito bites that we physicians like to use with the sophisticated name of exaggerated response to arthropod attack. This is changes in the skin where the skin and the eosinophils that are cells that react in the skin, they really create a unique infiltrate and a bigger reaction at the site of the bite. This can happen even without any CLL cells in the skin. It's just a unique feature. So we always recommend to use repellent or even clothing. There is now very nice clothing that I recommend to my patients that helps to avoid mosquito bites. Why to see a specialist with the CLL? Well, I think there is a lot of exchange of information that happens in our clinic every day when we visit with our patient. One of them is the concept of survivorship. I have the pleasure of directing the survivorship clinic for CLL at my institution, and by the National Cancer Center definition, a cancer survival is a person with cancer from the time of diagnosis to the end of life. So it's very important to take care of the survivorship component. And often what we see is that the primary care physicians are a little bit hesitant when they interact with you because they may say, oh, you have CLL. I'm not sure this is right for you. Go ask your CLL doctor. But then when you come to the CLL visit, most of the time that we like to use is used really to discuss your disease, and if you are in therapy, to discuss the therapy and the results of the therapy. So I feel that survivorship often is not given enough time, and this is why we created a survivorship clinic that every patient with CLL sees once a year to dedicate time to the survivorship initiative. And I know there is a good number of survivorship discussion at this meeting, and I find it very appropriate. So we follow an algorithm. This algorithm is open to the public. Actually, anyone can go to the MD Anderson website. There is a page for algorithm. There are algorithms for treatment, but there are also algorithms for survivorship, and this is the one for chronic lymphocytic leukemia, where we focus on different areas, the surveillance, the immunization. We tend to intervene on comorbidity, psychosocial functioning, and risk reduction. In particular, this page, I think, is important and is where all the cancer screening recommendations are listed. Really, really important to follow all those cancer screening, particularly the dermatologist visit for the cancer screening, because we all know how the easily treatable superficial skin cancer are common in people with CLL, but also there is an increased risk for melanoma, so this really needs a visit to the dermatologist is a must, and we work very closely with our dermatologist colleague. The other important component is vaccination. I have a very hard time in Texas with vaccination. People are not really open to vaccination. I'm going to frame my vaccination list and put it in the clinic, but still I don't think it's going to work. But I've been able to convince the importance of certain vaccination, particularly shingle vaccination. This is shown to be effective in people with CLL and reduces the risk of shingle, that it's instead a risk present in everyone with immunosuppression and stressor in life. The importance of vaccinating for influenza, pneumonia. I do recommend RSV and all the other recommended vaccination that may be based on your occupation if you are in the medical field. It's also important to consult with your CLL physician before traveling, because all the vaccination that people with CLL should receive are a dead vaccination, no live or attenuated vaccination. But if you travel to some exotic country, There are some vaccinations that are live, like yellow fever, or you may want to do a certain type of prophylaxis for malaria that may be different from the one of other people that travel with you. And then just to conclude the part of this review of CLL, it's really important for CLL people to stay healthy. I know there is going to be a session at this meeting on exercise. Exercise has a real benefit, not only on your psychological health and your physical health, but there are also indications that can improve immunofunction. We have published a report on health for CLL. That is a pilot study we conducted of exercise and diet in patients with CLL. We did correlative studies looking at the T cells function and NK cell function that are part of the immune system, and we saw some improvement. We also found that the coaching strategy that is mostly remote was working well. So we have expanded that, and we have now ongoing Health for CLL 2. That is our second version of the study, where we follow American diabetes recommendation for diet, ADA diet, and we do exercise with strength exercise that really has been having a major impact on the level of fatigue that some of my patients have. So this concludes my review of the CLL basics. Thank you, and I'm happy to answer any questions.
Thanks very much. That's a fantastic overview of the basics of CLL, and I appreciate it's a lot of information and potentially a lot of new information for some individuals, but I'd like to open it up to questions if we could. I can't actually see where the microphone is. Oh, I see. Yeah, so we'll just get people to raise their hands nice and high and hold it up, and we'll move the microphones over to you. And I don't have to start this session because there's hands already up, so that's great. Thank you so much for doing that.
I've got a very simple question. It was your last point on vaccination. I don't know if you know, in the U.S., well, probably that's where it started. Measles is now a big deal, and it's a live vaccine. And I asked my CLL specialist, and he's sort of ambivalent. He said, you're under treatment, your blood numbers are low, you've survived COVID twice, measles vaccine, he didn't think should be an issue. What do you think about that?
So this is a question that we are asked very often. We work with our infectious diseases specialists. What they recommend is to check your measles titer. There is actually a blood test that can be done that will tell what is your titer toward the measles. And then the risk for taking the vaccination, again, depends where you are in your CLL journey. Because if you are early with a fairly maintained immune system, even if for any reason your titer will be low, it's probably safe to take the vaccine. But if you are on treatment, particularly if you're receiving a medication like rituximab or obinutuzumab, really there is no point to take the vaccine because you are not going to be mounting the appropriate response. Of course, it's important to also study your environment, because it's unlikely that you'll be exposed just by chance. Usually the exposure is related to family member and having young children that are not vaccinated. So I think it's important to sit down with your family, and if you have somebody that is hesitant with vaccine in your family, you may want to bring the point that for you, having your family vaccinated, it's very, very important, more important than maybe for other people. And I shared it with my colleague at another meeting, I did have a patient under treatment that shared that her grandchildren are not vaccinated, and so I had to give the very hard advice of this patient not to see the grandchildren at this time. which is something I don't like to do, but I'm kind of obliged to share.
It's coming in the...
Hi, good morning. My name is Diana. My husband, this is very new for us. My husband was just diagnosed 4 weeks ago. I was lucky enough to just see if a CLL Society of Canada existed, and it did, so thank you for all of this information so far. I have a very basic question. Are you born with this, or is this developed, or, once you start seeing the onset of symptoms is when it happened, or?
So this is a good question. You are not born with it, but the disease most likely has been in your body for years before it becomes evident. And we know this based on the study that have been done in people with the monoclonal B lymphocytosis, that is the precursor. So it's very slow moving, probably has been there for a fairly long time, but no, it's not a disease that we find in childhood. And even below the age of 30 is extremely rare. We did have a couple of cases in the teens in the whole history of MD Anderson. We're talking about more than 30 years. And probably those were familiar cases.
Okay, and the second part of my question is it beneficial to test our 3 teenage children's blood for this? Is this like I know it's not hereditary, but is there a common gene or something that lives?
So this is something that I often discuss. And no, I wouldn't do any testing. This is not like some certain type of colon cancer that, people have polyps, and so if you do a colonoscopy and you remove those polyps, you won't have the colon cancer that runs in your family. But I feel that once the children are of age, maybe teenager or older, they're able to understand what's going on with